thank you, Sarah, for that introduction. As Sarah said, today I'm going to be talking about a project that the Insight programme team completed as part of an Imagine series on faecal incontinence. So the Innovation Observatory's primary patient and public involvement is undertaken through the Imagine series, which is grounded in rapid evidence synthesis methods, qualitative theory and horizon scanning, and uses the knowledge exchange model displayed to provide key stakeholders with an overview of the global research landscape and innovation pipeline. And that overview is then used to facilitate discussion on stakeholder needs and priorities to determine if they align with the current direction of research and if the health innovations in the pipeline can effectively address key challenges and unmet needs. The intelligence that we get from the series is then translated through our industry programme to drive innovative solutions to those challenges and unmet needs that are identified. So the primary aim of this particular Imagine series was to identify faecal incontinence research priorities and innovation gaps of most importance to the key stakeholders for this health condition. And in this instance, when I talk about key stakeholders, I mean the public in its broadest sense. So patients, family members and carers, healthcare practitioners, guideline developers and policymakers. The secondary aim of this work was to gain an in-depth insight upon the highest ranked priorities and gaps. So how did we do this? We collated 3 streams of evidence. One stream was indicative priorities, the other was existing research, and the final stream was emerging research. And we collated these to inform discussion on priorities and gaps within an insights workshop. To give you a little bit more detail about this, the initial set of indicative research priorities and innovation gaps were identified in a survey that was sent out to the key stakeholders. It drew on their prior knowledge and experience, with these respondents being asked to suggest what they considered to be priority areas and why. The existing systematic review level evidence pertinent to faecal incontinence health technologies was identified through systematic searches of 9 bibliographic databases from inception to date. Pipeline trials were then systematically searched for from a start date of enrolment within the last 5 years, and the premise that they were still active. And to search for those trials, we used the Innovation Observatory Scan Medicine database. The evidence streams were integrated into an interactive evidence map, like the one I'm now showing on screen. The framework for the map in this project used the evidence streams as the rows, so the data types as the rows, and the International Continence Society faecal incontinence categories as the columns, so the type of health technologies as the columns. And the map was used to inform discussion within an online workshop. As such, it was presented to the stakeholders along with information on how to interrogate the map, with indications given of the gaps. So where indicative priorities existed, but evidence lacked, and redundancies. So in opposition, where existing and emergent research existed, but without indicative priorities. This then fed into the first interactive component of the online insights workshop, which was an informed expansion of the indicative priorities and innovations set by stakeholders, having had an overview of the global research landscape and innovation pipeline. The expansion was facilitated through Padlet. And then before ranking of priorities and innovations was undertaken, we used an online range voting method. The 6 broad research and innovation gaps that were ranked as being of most importance to the faecal incontinence stakeholders were psychological support, lifestyle interventions, interventions for long-term effects of living with faecal incontinence, educational interventions for both healthcare practitioners and the public, interventions for constipation, and interventions that took in the impact of cultural context on faecal incontinence. After this, small mutually exclusive group discussions were used to gain broader insight upon the highest ranked research priorities and innovation gaps. Interestingly, the following themes emerged consistently despite the topics under discussion. And they were the lack of education, training and guidance to support public and practitioners in their decision making, the pronounced impact and burden of living with fecal incontinence and the need to identify new ways to ameliorate this, the lack of psychological support available for the patient's family members and carers, inconsistencies in care given across the system and the need for healthcare service improvements, the need to address the stigma associated with fecal incontinence, the stagnation of treatments and management and the lack of innovative health technologies, and the need for health technologies and management to be tailored to cultural contexts, and the inaccessibility of available health technologies. So to conclude, what we found were research and innovation gaps, which remained quite broad. And that presents a challenge. It makes driving innovative health technology development or provision to meet stakeholder needs complex. There is consistency between the research priorities identified within this project and within historical priority setting exercises, which shows a recent lack of effective adaptation within this health domain. And although divergent, each of the 6 research and innovation gaps seem to be underpinned by a common set of stakeholder needs and demands. More research is required to unpick these broad topics and the themes associated with them, and to understand how innovation may address some of the current gaps identified. Thank you very much.